Namaskar, one more time. I apologize for being mute the first time. For somebody who's been in telemedicine and telecommunications and use of technology for more than 35 years, that was a bad start. My apologies. It's a great pleasure to be here today. And before I forget, let me thank Exito for inviting me and all of you assembling to listen. The subject is very near and dear to my heart. I could spend 25 days talking to you about it. Now, the 25 minutes are going to put a challenge, but I will have fun. I hope all of you are awake, because I want to be a little more sensational than our good colleagues, because I've been part of the history, I've seen history, and today I'm the oldest man in the room at 70 talking about a subject. The first thing is, there's nothing like seismic move. I do not believe it is seismic, because the shift has always been happening in healthcare. It's nothing new. So to introduce myself a little differently, behind me, you'll see in the corner there, a piece of telemedicine I did in India back in 2000. It was on 8th of September that Karunanidhi Sahib inaugurated the telemedicine link we established between MGR Medical University when Dr. Anand Kannan was the Vice Chancellor and Boston. I also worked with the Apollo Telemedicine. So telemedicine is a subject I have a long experience, won the national award in America in 1995. And today, hearing everybody talk around it, I thought I'd share some thoughts with you. The word distinction that was put together between Rajiv and Dr. Fernandez on virtual care, I know they're not there, but anybody could convey it to them, is of synchronization. The power of technology has allowed us to do asynchronization. I could have taped this and left it, but no, I sat and listened to you all, and I'm joining. So this is synchronization. This means more effort. More effort means more money. So that's how they were explaining it. Another issue that I heard from Dr. Fernandez was about documentation and the ability for a clinician to examine a patient across the digital divide. The issue is, when I did the telemedicine back in the early 90s and mid 90s, we actually enabled auscultation, examination of certain pathologies, including a haptic glove and remote EKGs and remote raising the blood pressure sphygmomanometer on the patient after you brought them to ease. So yes, we were doing it as professional technologists. It was not consumer grade. Today, when we have come to consumer grade, we have lost a lot. The challenge for the community, and that's what I like to throw out, is to get back that professional grade. Today, we are able to use IoT devices, and that should come back. Today, we are so advanced in virtual reality, we should be able to set up a room at a pittance and be able to examine a patient as soon as they enter and transmit as much of information you can using infrared technologies. Pradeep Sheshadri did talk a lot about security. I have had the privilege of having NSF grants, National Science Foundation grants, to study security in healthcare. And the key piece is we don't understand the distinction between privacy and security. We use the two words exchangeable, and that is not the truth. The trouble is bigger than that, because we all assess ourselves to and demand we get anonymity. So with that said, remember, HIPAA and GDPR are just two rules for foreign governments or foreign regions. But anybody in India doing work with these foreign regions needs to follow them. The panel was very scintillating. They had real ground level information. The issue of viability, the challenge of standards, they do exist, as Suptan shared. I call Suptan by name because I know the great professor for a very long time. So they exist. The question is, how do you implement? As for standards of the technology that are being adopted, there are certain organizations like KLAS, K-L-A-S-S. They do evaluate technologies and create criteria for technology people and clinical people to sit across the table and understand what do you get with this Cadillac service and what do you get with this Bentley in your garage. So that's another thing. I like the thought about data. Yeah, I work with a lot of Indian friends. Unfortunately, our failure begins at the door of the hospital where there is no scrutiny on finding out if the patient had been registered before and if he was not registered before. I seem to have been dumped. My slides, can you see them still? No, okay. So Dr. Shah, nice to see you. Welcome late. How about that from a non-moderator? So that's where I've been. I loved everything I heard from all the people on the panel. With that said, let me embark on my little story. I'll move fast and I'll share with you the slides. Can you see my slides now?
Yes. Yes,
Thank
Dr.
you, ma'am.
Moidu. Yes.
Thank you, ma'am. So I'll talk a little about ETTMA. I just want to tell you that I retired for the third time and in December of 2019, took a holiday, came back, then friends approached me and said, hey, Moidu, can you help us with developing a decision support guidelines platform for COVID? It was the 7th of March and I realized we already had 35,000 papers published on COVID-19. They were all observations. There was no evidence. And since observations were coming just as what they saw, it was like the three blind men and the elephant. Depends on what they touched. So I began organizing webinars on COVID-19, not to educate people, but to raise awareness and share experience, emphasis on the word experience. And then somebody young reached out to me and says, Dr. Moidu, you got to join us. And I said, I'm not moving from Orlando. I live in the Magic Kingdom. And would be love to hear what you're trying to do. After some time, I found these young people had a great vision. And it's not anything but Atma. It's been written in English to get the right enunciation. It's the soul. And these are young Indian and American kids. And they have built this company with an idea and an objective I'll just explain. I shall then cover the healthcare paradox. I'm a trained physician from the Armed Forces Medical College. I am a critical care pulmonologist. COVID was entirely my domain, had I been practicing. I have a doctorate from a Swedish university, the University of Linköping, in medical informatics. I have been a health informatics professional for nearly 36 years. So I will try to cover all sides of the story. I will talk about a little about the technology evolution, and then we'll talk about future. I've already covered about 8 minutes of my talk, so I've got to get moving faster. So ETTMA is about evolution, transformation of people. You can do no technology transformation without people. Technology is only a vehicle. You have to be able to think from multiple angles. In these years of the last bygone days, we dropped ourselves into silos and we thought we were greater experts. But that's the reason why COVID struck us so hard, because all of us just saw the symptom and decided we have to do the support. The symptom was breathlessness. The cause was not pulmonary, it was endothelial. So that's another story. As far as things go, doing something as simple as ancient wisdom of Jalnethi, and you will reduce the chances of you getting COVID, because you will not let the viral load increase in your nose and stomach. I'm sorry, pharynx, my apologies. I've been awake all night, so forgive me. So let's talk of informatics stages and advances. We were in an age where we first were experimental, and we stayed experimental for a long time, till 95. And then we began to implement. The early adopters to 2004, barely 4%. Then there came the mandated adoption, which people call that as Obama. Obama had nothing to do with it. It was the chaos of economy in the American environment that led to people to realize the one place we can start saving money is when we start going to create jobs in America and improve the quality of care. And then the transformation began, and that's just the big thing, because now with transformation, we are no longer looking at silos, we are talking of integrated systems. And today, you can't say you have a health information system, you have a health information eco-environment. No single solution is adequate to manage all the types of data and the sources of data and the controls of data you require. So yes, I began a long time ago in artificial intelligence, as far back as 1988, when I published one of my earliest papers. It was about medical practice decision-making, a logical model. And that's when I was a grad student. And it was an experience that I would still share proudly today, because fundamentals have barely changed. It's the applications and integration at applications levels that have been changing. Data analytics, I can't stress enough. You can do a simple thing. If you're trying to tell your doctors how good they are, you can just keep a set of records on them and do it. I was the chief medical information officer at Orlando Health. And this is data from there. And that's why the Arnold Palmer Hospital, which is one of the largest pediatric hospitals in the United States, among the top 5 anyway, I was the CMIO, Chief Medical Information Officer, and we had in 2010, 90% adoption of electronic ordering. In India, you don't do it yet. So if you're trying to do those high things, remember the foundations don't lie. You're falling from a plane without your harness, and it won't deploy, and you can know what the end will be when you meet Mother Earth. This is a project I did, which tries to tell you we started integrating data very early And we took the clinical data capture systems, put it through a gateway, put it in a smart system, smart as Suptan described, where you could write rules and you could write rules for your patients, and that would generate an alert that was delivered to you on your BlackBerry. So when I say BlackBerry, you should know BlackBerry was the big thing till 2010, and we had done it by then. So this is just to share with you what has been in the past, but sure, it can be done. And this was incidentally developed in partnership with a large Indian software development center. So yes, I live in America. I could be faulted for having an accent, but I don't think I have left India. There's a flag behind me. So let's talk about advances in medicine. In 1980, this is the number of facts and concepts a medical student assembled and assimilated at this pace. And that was a study done by two doctors in King's College Medical School in London. In 1980, there were 1.5 pages on cell membrane description. Today, that cell membrane description is in 1.5-inch thick binded books. So imagine the explosion of information. And I'm only talking of cell membrane dynamics because that affects drug delivery. And a lot of more is now known about the genes and the gene therapies, etc. So we are suffering from data deluge. We have too many super specialists. They look at the left ear, they won't look at the right. We have got a lot of new drugs. What does that mean to you? Depends. It's strange, but I must share this with you, and I'm happy to be wave hip on this. 6 years ago, I was found strangely with HbA1c of 13 in a random examination to get my cataract removed. God, 13.5. And I said, what happened to me? Anyway, I want to tell you, day before yesterday, I went for my medical exam to my doctor, and now I'm 6.1. What did I reverse it with? Medications and following ancient methodologies on diet. Reversing metabolism is the answer, but it's no medication for it. Guess what? Nobody's going to promote it, except doctors who really care about you. Because if we want to really care about people, we need to get them off our list. I've never heard a doctor ever tell a patient, including myself, till I got this realization recently, that I'll see you in 6 weeks, I'll see you in 6 months, I'll see you sometime soon. Nobody says, I don't want to see you again. That's life. Let's believe it. Artificial intelligence. It's a technology, as I shared with you, it's been here for a long time. And I want to tell you, technology doesn't matter. How you implement it, it matters. Just by knowing what a person uses is enough to make the person realize when they are being smart and when they're not being smart. The value of the data is only if you are able to analyze it. And the more we build portals rather than single system centers, we will do a better job. But while I'm talking about the good side, let me tell you there's the bad side. All is not good. Having worked on evidence-based practice of medicine, developing and designing clinical decision support systems, I must bring this quote to you from Marcia. Dr. Marcia was an editor of the New England Journal of Medicine for over 25 years. In 2006, she wrote this statement. that she can't believe in all the research that's been published. And that's where it goes back to tell you, be alert, be clear on yourself. It's very easy to fool even the biggest companies that serve money. Every time Mr. Zuckerberg goes before the Congress, his Facebook shared price goes up. It's reality. Go check it. And then there was this big scam by this lady called Elizabeth Holmes, a dropout from Stanford. She built a company that would take a drop of blood and give you all your results. All your results. All your results were all a dream. She used the name of Edison to design a machine. She built a company from scratch to $10 billion. And guess what? It vaporized even faster. So when we're looking at the future, that's another concern. Startups are great. But if you can't ask the emperor, where are the clothes? Remember, the scam is on you. So let's talk about the healthcare paradox. I want to shift through this a little faster because all of us have been trained in hospitals and none of us have been trained in primary care. We all know how to take care of acute patients and we do very little about chronic care. The issue of funding is all in the institution and very little on the providers. This is shifting. You have more chronic care patients, more diabetics and hypertensives than you have patients with acute myocardial infarction. But guess what? The investments go that side. So I'm taking up the thing because I saw nobody go for the investment angle of it. And it's worth thinking about it. And with telemedicine, you can do a 90% time monitoring of your people. In technology, all these things are improving. But when I talk about bots and robots, before you deploy them, please, for heaven's sake, do some focus group studies and see how the patients feel. While people in Nigeria in a Pricewaterhouse study accepted all bots and robots, the people in the educated societies of Europe and America were very hesitant. Now remember, the biggest shift is because care focus is shifting. It's shifting because the pandemic is here. Knowledge is being rewritten. Where are we in the future? At ETTMA, I'm involved with a group of young people, very talented. And for the first time, we're not looking at silos. We're trying to pull the data up and try to see the collaboration and things going right. If Hurricane Laura, as it hit this morning in Texas, the question would have been to plan for all those patients who are going to get surgery today, or all those patients who are coming to see you today, and reschedule them. It's very easy. Scheduling systems exist. AI rule can be implemented. Things can change. But the point is, we have millions of combinations, dozens of accesses. How do we align everything for us to work together? It'll take time. It won't happen overnight. And there'll be a lot of angles before we get to the point of understanding energy, paper, healthcare, policy, technology, environment. All these things in this Rubik Cube have to be realigned. And that's what the young team at ETTMA is all about. We've already started and developed a product called Abha, and it's an AI application as a service. The company is not very old, it's barely 4 months, but the lockdown made us more productive, I assume. We have got a solution going on, genetic representation and genetic analysis. This is an insight into Abha, where it takes the images and allows you to see what it looks. I talked about IoMT devices. This is where I take a few seconds more than I'm scheduled. I heard myself. So let me say this, that the way we deliver care is in episodes, acute episode and episodes in the clinic. We need to move from there. We need to know the patient all through their life cycle. They don't stop being patient between visits. And a future with IOMT devices is here. The devices exist, but our greatest challenge is one that engineers do not think about. That's a challenge I leave for you to think about. And with that, I'm ready to take any questions if I'm allowed. Otherwise, I want to tell you our goal at ETTMA is to work with people, build connections, build things. We are not soloists, and our two products are up in the market so fast in 4 months is because some people were trying to do it. We were able to move it a little faster. With that, I'm off. Thank you very much.
Thank you, Dr. Moidu, for that very valuable session where you shared your perspectives and insights on the potential of informatics and telemedicine and the transformation. Thanks a lot for joining us. We have a question from Pallavi Roy. What can we do to make data related to healthcare more quantifiable?
It is quantifiable.
Right.
That is not a challenge, because when you say patient is better, that is a qualifier. That's not saying that. But if you look at any disease, whether it's emphysema, where I have a lot of experience, you can grade the disease into 1 to 6 and decide and define the patient when admitted was at grade 6 and is being discharged at grade 4. So you know what your outcomes are. If a patient like me with HbA1c of 13.5 walks out of your office at 6.1, it's a great day. My doctor was my resident some 15 years ago. Poor chap couldn't believe himself. He has never seen anybody turn the switch backwards. But the fact is, we have not spent time reading about things of our past, our heritage. You know, in the olden times, there's a beautiful book written, No Food Out of Limits, NFOL. I know the author because she is a college junior of mine, Manushi Bhattacharya. No Food Out of Limits. And this NFOL is such an insightful story. Reading that book and adopting many of the techniques she wrote in that has really liberated me. So making things data more quantifiable is there. Anything else?
Thank you, Doctor. We have another question. Should a doctor be well versed with integrated systems or information systems and technology management?
You come to my favorite subject, manna from heaven. Let me say this. We all think we all know how to use our iPhones. It's a consumer device. They sell it to you without a manual. How do you expect everybody to know how to do everything? It's impossible. We have graduated doctors. Well, I graduated from medical school in 1972. For care of a cardiac patient, there were two things available, pethidine and oxygen, not even aspirin. Guess what? Today, they have a plethora of markers to test. They have a host of drugs to deliver. And all these were developed by my generation. So let me challenge the next generation. Begin with data literacy. Every time you send an email or you ask for somebody's data, there is a lot of information being shared. Between the data, the information, and the knowledge, there is a pipeline of activity which very few people tell you, and that is the pipeline of data monetization. I have been teaching data literacy for a very long time. So if I drifted back 4 years ago to teach at Hofstra University, it was because they have started a new medical college and they were following a new educational system. Stanford is the only other medical college I know where they teach data literacy. So yes, we can see the data, we interpret it one way, not all of us interpret it the same way. So for example, the PFT, the pulmonary function test given to every patient of respiratory disease, is actually an evaluation of the physics of respiration, nothing to do with the exchange of gas, for which we have ABG, the blood gas analysis. And that's where we got to realize these things are clinical and they will be conveyed. But there are a lot of things that are not clinical. By teaching a machine that all my patients with the HbA1c over 7.2, I must see them every 90 days. Everybody who's got it over 8 every 60 days, you can plan your care for anybody. And that's where understanding of information systems has to be more than an awareness of that dumb computer in the corner of the room. Thank you for that lovely question.